Okay, it seems like the flow has slowed. So why don't we go ahead and get started, and more people can join, obviously, as we go along. Well, thank you all first for joining Data for Impact for the webinar today. Our format will be to answer questions after the presentation. You can feel free to put questions in the Q&A box. It's better to put them in the Q&A box than in the chat. So you could feel free to do that as we go along, but we are just going to hold answering questions until the end. And we do have time planned after the presentation for that discussion and Q&A. So just briefly, for those who are unfamiliar with Data for Impact, or D4I, we are a USAID-funded cooperative agreement and an associate award of measure evaluation, which you may know from the 30-year plus history of measure evaluation. And D4I aims to generate strong evidence needed for program and policy decision-making through the use of available data sources and the generation of new data. We also aim to strengthen individual and organizational capacity to generate and use evidence, and facilitate and enhance the use of data for global health programs and policies through compelling user-friendly data organization, visualization, and communication. Today's webinar is the first, we're happy to announce, in a new series that we have focused on integration. So why integration? We chose this theme because integration is of increasing importance in global health in many ways. I note here just 3 examples. There's a myriad of examples, but here's 3. So we seek more and more to improve the integration and use of data from routine and other sector information systems for routine health and other sector information systems for evaluation. There are also an increased number of projects tackling a range of health issues at once, as well as projects that are spanning multiple sectors, so health and environment or health and education. We have several evaluations on both of those topics here at D4I. And this means that there's a greater need to evaluate and learn from these integrated models. Lastly, related to the topic of today's presentation, intentional integration of gender and other equity considerations into global health services and evaluation is an ever increasing need. So you can see here our second webinar in the series will be on March 22nd. That will be focused on integration of DHS data. There's actually 2 different presentations giving examples of integration of DHS data planned for that. You can be on the lookout for that on our social media, on our website, and through our listserv. We'll have an announcement, and you can register for that in the next couple of days, I think it'll be. So now I would like to introduce today's presenter. Dr. Katherine Andrinopoulos is going to explore the development of a tool to assess gender competency among family planning providers. Dr. Andrinopoulos is an associate professor in the Department of International Health and Sustainable Development at Tulane School of Public Health and Tropical Medicine. That's a mouthful. And a senior researcher with Data for Impact. We're very happy to have her on the team. She conducts applied research in the areas of gender, HIV, and family planning. Let me stop sharing my screen, Katherine, so you can share yours.
Great, thank you. Okay, great. I'm so excited to be able to join you all today, and particularly excited to be the inaugural presenter for this integration series looking at integrating global health monitoring, evaluation, and learning. Gender is definitely one of the most cross-cutting factors across health issues, and so I think particularly relevant when we think about integrating concepts across health programs. The work I'm going to focus on today is thinking about gender competencies specifically within the context of family planning. However, I think there's really strong potential to apply this concept of gender competency and building skills in this area across other health areas as well. So as Jessica mentioned, we're going to hold discussion until the end. But as I go through the presentation, I'd really love for you to think about how gender competency might apply to your health area and ways that we might be able to translate some of what we're doing here to other areas as well. Of course, the material I'm presenting today represents a work that has been conducted by our team, which includes Courtney McGuire from D4I and our research partners in Ghana, Dr. Phyllis Deko-Geki, and our research partner in Uganda, Dr. Ibn Misango, as well as our USAID support team and our D4I and country missions in each country. So the objectives of this presentation are to introduce the gender competency framework and the 6 dimensions, to explain our process for developing a tool to assess gender competency that aligns specifically with each of these dimensions, and to share how we adapted the tool based on our first round of piloting in Ghana. I am going to turn off my video as I present the slides until the end when we have discussion, just to save everyone's bandwidth. Okay, so as I mentioned, the goal of this activity was to develop a global tool to measure gender competency among family planning providers. And so, throughout all of this work, we needed to consider things that were related to the nuances of gender and how that affected people's lives, but also to the fact that this is something that we want people to be able to use in many different contexts. So thinking about aspects of gender that could be kind of reflected on, that were global in nature and not overly idiosyncratic. The audience and user of the tool are family planning providers themselves. And so we constructed the tool to be user-friendly for providers. This informed some major decisions we had to make about how we would assess gender competency and what kind of method we would use for that. So we wanted it to be user-friendly for providers, and that a team of providers could use this to assess and reflect on their areas of strength and weaknesses in terms of gender competency. And so we have thought of not just the questions, but also a discussion guide that would help providers in this area. The tool is designed to be useful at critical points of provider assessment, including pre-service assessments, for example, so that you could focus on specific areas of competency in trainings and nurse, medical, community health worker curricula and other pre-service opportunities. And that the tool, would also be useful to ongoing quality assessment and improvement for programs. The tool complements an e-learning training that is currently publicly available and to providers that might be of interest to many of you on the call today. This training was developed by another team concurrently with our development of the tool. The content of the tool and the training are based again on these 6 dimensions of gender competency, which I'll describe in detail in this presentation. The development of the tool has 2 planned phases and 1 potential phase. We are in phase 1, and we'll focus on this for today's presentation. In this phase, we designed the tool and have done so using an in-depth literature review and expert review and cognitive interviews in Ghana. And also the next phase of this work would be to provide TA to 1 group of providers to use the tool and the accompanying discussion guide. And we expect to do this either in Ghana or Uganda. It is also possible that a 3rd phase of the work would allow for larger scale application of the tool so that we could assess the psychometric properties of the tool and construct validity with more precision. The gender competency framework was developed by USAID and a team from the project Human Resources for Health 2030. To do so, they conducted formative research in Ethiopia and the Philippines, including in-depth interviews with providers that led to their construction of a definition of gender competency and each of the 6 dimensions. At the point we began the work on the tool, the team had developed a report, presentations, and a draft of the training for providers. And so our tool is not based on something more broad, but is very much linked to this training in each of the dimensions that are outlined in this framework. This is a visual of the online training, and I included a link in the previous slide in case you want to access the online training. Competency in each dimension means that a provider has the requisite knowledge, attitudes, and skills in that area. The competencies build on each other. Therefore, there's purposeful reinforcement and duplication of related knowledge, attitudes, and skills across dimensions, which means there's also some purposeful duplication in our tool. And one of the reasons we chose to design the tool so that each dimension is measured by a module that stands alone, or that the tool could be taken together. The definition of gender used to guide this work is that gender is the economic, social, political, and cultural attributes, constraints, and opportunities associated with being male or female in society. It includes the roles, behaviors, activities, rights, and responsibilities that a society considers appropriate for women, men, girls, and boys. The first of the 6 dimensions in the framework is gender-sensitive communication. And this refers to a provider's ability to transmit information through verbal and nonverbal communication in a way that recognizes unequal power structures and promotes equality for all clients. It should be person-centered. The second dimension of gender competency is promoting individual agency. This refers to the provider's capacity to support an individual client's voluntary and informed decisions about whether, when, and how often to reproduce without pressure to conform to gender and cultural norms. The third dimension is supporting legal rights and status, and this refers to the provider's ability to provide information and services to clients in accordance with rights and local laws and without interference of personal bias. The next dimension is engaging men and boys as partners, and this refers to the provider's recognition of men and boys as supportive partners to women and as potential users of family planning. It can be demonstrated with male or female clients and couples, but should always be anchored in women's preferences and consent. The next dimension is facilitating positive couples communication, and this refers to the provider's capacity to help clients articulate, discuss, and come to agreement on reproductive intentions and to make joint reproductive decisions as a couple. Finally, the 6th dimension is addressing gender-based violence, and this refers to the provider's ability to understand and recognize gender-based violence, incorporate principles of do no harm into family planning services, and to provide appropriate referrals and reinforce the right to be treated with respect and to live without violence for their clients. I'm going to take just a moment here to look into the, okay, good. I just wanted to make sure I wasn't missing anything in the chat. Okay, so those are the 6 dimensions. As I mentioned, when we began our process to develop this tool, the first thing that we did was to examine the literature. And we wanted to see if there were instruments out there that could be adapted for the purposes of measuring gender competency. There's been a lot of instruments designed within family planning to look at quality. Mostly these have focused on communication and counseling skills. And sometimes we were able to find some instruments related to cultural competency in a more broad way. But there was nothing that was specific enough to be able to map to the specific nuances of gender that we were looking to capture in each of these dimensions. From our gray literature, we found 16 tools. And from that, we extracted about 100 different questions to use as references during our tool development phase. Whereas we didn't find specific ones that would map directly, we were able to learn from the way some of the questions were structured and the way some of the things were worded to kind of tweak them for our needs in certain cases. I do want to note that we found 2 references out of the ones that we looked at that we thought were particularly good references that you might be interested in. The first is this tool from the IntraHealth International Prime 2 project that was supported by USAID. The Better Practices in Gender Sensitivity was it as a useful toolkit. And then there was also the Improving the Health Sector Response to Gender-Based Violence, a resource manual for healthcare professionals in developing country. And this was developed by IPPF and PAHO. Other useful background resources for those of you interested in this gender competency more broadly include some conceptual material that we looked at from the Gates Foundation's Beyond Bias project, and the Emerge platform, which stands for Evidence-Based Measures of Empowerment for Research on Gender Equality. This platform is a powerful resource of measures, and it is based out of the UC San Diego. But as I mentioned before, nothing that we found quite fit our needs. And so we were left trying to design many of these questions for each of the different modules by constructing it on the formative work that had been conducted by the previous team and all of the work they put into developing these dimensions. So as many of you probably have looked to develop instruments or tools to measure different things, we faced some common challenges that conceptually as we had to make decisions about how to construct the tool that many of you probably have also experienced if you've tried to create measures yourselves. And the first was deciding on how to assess dimensions, especially in relation to skills. Because to have the requisite competencies, you would need to have the knowledge, attitudes, and skills in certain areas that, of course, we want to see to lead to behaviors when providers are working with clients. We considered whether or not to use observations or vignettes versus the statements with Likert responses, which is what we did land on. And the reason for not using observations or vignettes was that we wanted this to be useful for providers to be able to take themselves and reflect on their responses. And so vignettes and observations would have required a little bit more in terms of the scoring difficulty and also inter-rater reliability and training of people who would be using the tool. And so we wanted the tool to be something that we could put in the hands of providers to use to assess and to reflect on their skills. The other kind of thing that we thought about in measuring in developing the tool was measuring gender dimensions across global context. So I mentioned before, gender can be very culturally specific, and we were looking for ways to think about these gender knowledge, attitudes, and skills that could apply across many different places. And so the formative work was conducted in Ethiopia and the Philippines. We very purposely look to pilot our instrument and have another opportunity to explore these dimensions in Ghana and Uganda, trying to get at many different cultural contexts and hearing about how providers respond to these dimensions. Another challenge was crafting statements that didn't have an obvious right answer. And so there's some complexity within each of the gender dimensions. And so we were looking for ways of explaining how gender was a component of the knowledge, attitudes, or skills that we were looking to represent with our questions without the statements being overly complicated. And so you kind of have to strike a balance between being too complex in the concept that you are measuring versus something that is easily interpretable and easy to understand by the person taking your survey. We thought about using negatively worded statements as a way to combat acquiescence bias, or the likelihood of just like answering always with the first response option of strongly agree or strongly disagree, depending on how you order your response options. And we looked into the literature around how to use negative statements. In the end, we were careful to avoid what we call polar opposites, where someone has to choose between one or the other that may not be exactly opposite of each other, and also to be careful with how we included negatively worded the participles in our statements. Finally, and you'll see how our piloting helped us pick the appropriate response options as we kind of struggled with which ones to use there. The other part of this was the tool length, right? So we have 6 different dimensions, and each dimension has a lot of depth to it. And so this is where we landed on different modules for each dimension, some purposeful duplication in case people were to take the module on their own rather than take all 6 modules. But again, striking a balance between capturing everything, getting that content validity, and not having an overly long tool that would be prohibitive for providers to use. After constructing our tool, we had a panel of experts review and provide feedback. And this included people within the USAID and D4I team, but also purposely people external to our team and who were family planning experts in different areas. Some of the most useful feedback we got as they kind of were able to help us think about the face validity of the instrument was reframing some of the questions to I for family planning providers rather than talking about family planning providers in general, and some of the wordsmithing to unpack these gender concepts that I mentioned were pretty complex. So after all of this work, we ended up with a draft tool that had 76 items across the 6 domains, and which ranged in item length from 8 to 17 items across each of the modules. Our method for piloting was very specific. We were using cognitive interviews, so something that is more narrow than an open-ended interview or some other kind of qualitative technique. And the reason why we used cognitive interviews for the piloting is because we wanted to really be able to assess whether or not participants understood the intention of the question and whether that was easy for them, and whether the wording could be made more clear, and whether they could map their answers to the available response options. So that's why we chose cognitive interviewing. And so this form of interviewing is based on cognitive science and work by Turingo and others in this area that define the cognitive response process for answering questions to have 4 steps, as I've outlined here. These include comprehension. So do they understand the question? And so these are the 4 steps someone goes through when they're answering a question. Comprehension, so first they have to understand the question. Retrieval, the ability to easily recall the information. Judgment, this process of reflecting on how accurate they feel like their recollection is. And then response, mapping their answer to an available response category that you have. And we were really interested, as I mentioned before, in whether or not our statements were interpretable, easily interpretable, and could be, if they could be worded any more clearly. This is a visual of the interview guide that we used, and we based it on an instrument that had been developed by Mahua Mandal for cognitive interviewing when her team developed a measure of reproductive empowerment as part of the measure evaluation project. And just to kind of walk you through this guide, which looks very different than what your survey would look like or what an open-ended in-depth interview would look like. We began by stating to the participant that this is like a survey, but different, because it's not, we're going to ask for your answer, but then we really want feedback on each of the items. And then for our team of interviewers, we have this to fill out, which is giving the item, marking the response, and then having specific probing questions around repeating the question in their own word, explaining potentially complex words within the statement, in this example, power, and then having them explain to us why they selected their particular response option to make sure that our understanding of what we asked and theirs was similar. It's in this part of it that we're also gaining a lot of richness about how each of these gender concepts influences provider in their particular context. And then in this final column, we had space for interviewers to mark whether it was easy or difficult for the person to respond to this item and why, which helps us very quickly recognize any kind of issues with an item and move forward with revising it before it's piloted again. So as I mentioned, our initial work was conducted in Ghana to pilot this. We applied the cognitive interviewing tool with 25 family planning providers. We began with 20 interviews that were conducted in 3 regions: Greater Accra, Eastern, and Ashanti. Excuse me. The team reviewed audio recording and notes from each of these interviews and incorporated feedback into the tool. And then we went out and did an additional round of 5 interviews to assess each of the modules with the revised instrument in Greater Accra and in Ashanti. And so this fieldwork was conducted between June and July. And the team met many times throughout the field work so that we could be really responsive to what we were hearing and adjusting the guide as we went along. And this included work with Ghana Health Service and our research partners throughout that time. So this is a visual of the different facility types that we made sure to incorporate in our sampling when we thought about different providers. This is an instrument we want people to be able to use across the many different types of providers that are in family planning. And so you can see here the regions, and that we were very intentional in making sure that we talk to providers across different types of health facilities. We were also very intentional in talking to different types of family planning service providers so that we could get feedback from each type. And so you can see the different cadres that were included here, and there are even some subspecialties, of course, within each of these broad categories. One limitation that we had was finding male participants, and that is something that we are doing with more intention in Uganda now that we go and are able to recruit more providers. So we had some general findings across the piloting of the instrument, and then I'm going to go into some of the nuances for each dimension. But generally, participants understood the intent of most questions. We had some minor revisions to wording. We were able to drop 14 items, so the modules currently range from 8 to 15 items. We were able to pick up on the central importance of this one concept that really hadn't been emphasized quite as much in the other materials that we'd reviewed from the gender competency framework. And this was the central importance of religion and how different side effects and aspects of family planning, for example, spotting, could impact the ability to pray, the ability to have, how it might impact your relation with your spouse. And so needing to incorporate a little bit more of that. And so just a very, simple way that we incorporated this lesson learned is in this example statement here, talking to a client about family planning pressures they face because of social, cultural, or religious beliefs is a necessary part of counseling. So this is part of our agency module, and we incorporated religious beliefs there. We also changed some of our response options. So we initially were using never true to always true, and we decided to go back to strongly agree and up to strongly disagree, and piloted that new response format with our last 5 participants. Some other examples of reworded questions here from different modules include, I'm able to explain things differently based on the different needs and understanding of male and female clients. And this is in our gender sensitive communication module. This is an example of where we were struggling with a little bit how to use the term gender or the concept gender norms without using those complicated terms, and instead break it down into what we actually mean, which is the different needs and understandings of male and female clients without using kind of larger cover terms like gender or gender norms. Helping a client make an informed choice about a family planning method includes explaining contraceptive methods that can be used with or without other people knowing about it. And so this is part of our agency module. And this picked up on something that we heard from the providers about the need to be able to counsel their clients in a way that would help them use family planning discreetly to maintain their client's agency. So this was a newly constructed item that we added after piloting. I can effectively counsel men to support their family planning decision, even though most contraceptives are for women. And so this was added to our module on engaging men and boys. And this came from interviews where providers, in talking about access to family planning, several of them began to mention the fact that the different forms of contraceptive were more limited for direct use by men. And so that was one of the issues that they faced. So I've already gone through each of the dimensions of what each dimension is, but I wanted to give you some sample items for each one as well. So again, if you remember the concept of gender sensitive communication, some of the sample items that we have are in understanding differences in power between myself and my clients helps me to counsel them more effectively. I'm able to explain things differently based on the different needs and understanding of male and female clients. And then we included this item that is reverse scored, again, to try and get at the acquiescence bias. It is difficult to separate my own cultural beliefs about men and women from how I counsel clients about family planning. In terms of promoting individual agencies, some of our sample items from the revised tool include, I can effectively counsel a female client on using a family planning method that keeps her out of trouble when others do not approve. So again, getting at that same concept of needing to provide it in a discrete format. Talking to a client about family planning pressures they face because of, we read that one before. And a couple's decision about the number of children to have should be left up to the man. So this would be a reverse scored item in the individual agency module. In terms of legal rights and status related to family planning, I'll just read one of our sample items from here. I should discuss all contraceptive method options with a client, regardless of whether they are married or not. Or actually, I will read one more because it was important. I know if spousal consent is required for sterilization in my community. And so I mentioned before some of our tension with developing a global instrument. And this is why here we very purposely worded things about related to their knowledge and what is appropriate in their context, because it's impossible to have, something that would fit across all contexts with more specificity, because the laws are different in different places. Engaging men and boys. An example item from here is men can be users of contraceptive methods themselves. They are not only for women. Again, getting at what I mentioned before, how some providers mentioned there were not as many contraceptives available for men. And so reinforcing this among providers that there are some things that they can use, like condoms and vasectomy. Facilitating positive couples communication and cooperative decision-making. Some example items are when a client does not know how to discuss family planning with their partner, I can help them practice doing so. And so getting at that it's not only through couples counseling, but that providers have the skill to be able to support clients in discussions that occur outside of the clinic setting with their partners about decision-making and family planning. Inviting sexual partners to talk together about family planning is important, even if they don't consider themselves a couple. And so this was one of the important aspects that was highlighted in the training, is that not all partnerships, not all sexual relationships that may require contraceptive use or thinking about family planning might be your traditional concept of a married couple, but could come in many different forms, and that providers should have the knowledge and attitudes and skills to be able to work with those clients as well. In addressing gender-based violence, a really major kind of emphasis here was on do no harm, and that you could have competency in being able to provide gender-related services without necessarily being trained in gender-based violence, which is another kind of deeper skill set that a provider should have. And so it's more on being able to recognize when there's an issue and to know how to refer on, and to recognize your limitations as a provider if you don't have training in this area, so that you do no harm when serving your clients. And so one example item would be, to protect the client, I should only counsel clients on gender-based violence if I have had training about it. So I mentioned before that in addition, that we really wanted this to be something that providers themselves can use. And so outside of these different modules with items like I just demonstrated, we've also developed a discussion guide that can be used at the end of each of these modules. And so this discussion guide begins with personal reflection questions for the person who took the tool. Key takeaways. So what are some of the key points related to that dimension? Answers for each item. And so I give an example of what that looks like here, where it's color coded, and we have what would be, the ideal answer for someone who is high in gender competency, and then an explanation as to why. And so our interviews to pilot it are really helping us also build out the context in terms of explaining why and providing more nuanced examples there. The discussion guide also includes group reflection questions. So if a team of providers wanted to assess their gender competency and then reflect on where they, as a team, have strengths and weaknesses, there's some questions to help them dive deeper into each of these dimensions and how it's affecting their work. And then, of course, we have a link to the e-learning course, which goes much more in depth for each of these different dimensions. So this discussion guide is seen as a bridge between your assessment results and then linking you to the training as well. So I mentioned that we will also be piloting the tool in Uganda. And whereas in Ghana, we partnered with Ghana Health Service to do so, in Uganda, we are working with the family planning activities supported by USAID. We just finished our first round of data collection, so super excited about that. We conducted 21 interviews with family planning providers in the Albertine region and Bulisa district just last week is when we completed that data collection. And then we're going through a similar process as we did before, where we're reviewing the notes and the audio recordings. We have created a spreadsheet that we use to examine information about each item, and And then we will discuss with the team and revise the items where necessary, drop or add new ones if that is required. The initial feedback we were excited to hear is that, most providers out of these 21 felt comfortable with the instrument. It doesn't look like we were missing any kind of major concepts in the items that we've created for each of the dimensions. There's some wordsmithing and some, maybe different ways of wording things that will be useful. And so some tweaking there. Interestingly, one of the things that came out, and again, this is just from preliminary feedback from interviewers, not being able to delve into the data quite yet, but some of their feedback was related to providing services to adolescents and how providers are subject to the same kind of gendered norms and pressures that the wider society is. And so they're dealing with adolescents, some kind of concerns over, if you providing adolescent services without, if the parents aren't involved or without the partner's consent can be more complicated, and that they could also face some backlash for doing that because of these concepts in the wider community that adolescents shouldn't be sexually active. And so that was one kind of new thing that we heard in Uganda that we had not heard in Ghana. So after we look at this data, we will do another round of interviews in Kibale district with about 10 providers to finalize the tool. I mentioned before that once the tool is finalized, our plan is to work with one team to demonstrate how to administer it and score it, and to use the discussion guide and make any kind of final tweaks that might help make that more useful for providers before we finalize everything. So again, I just want to thank everyone who has supported the work so far. I want to now open for comments, questions, and discussion.
Thank you, Katherine. So now if you have any questions, please feel free to put those in the Q&A, or if you want to raise your hand and then just open your mic to ask a question, that's another option.
And selfishly, I'm going to I think I started us off with a question around, now that you've seen both the concepts around gender competency, this training that's available, but also our instrument. How do you see, if you do, gender competency applying to your work or to your health issues specifically?
And also, if you'd like to respond to Katherine's questions and don't want to open your mic to respond verbally, feel free to put a note in the chat about how you see this applying to your work.
Oh, I'm just seeing in the chat, I want to acknowledge we have Samantha Wild, who was working with HRH 2030 and was one of the developers of the gender competency framework. So we're glad to have you here as well. So some of the things that we have, heard or talked about with providers as we're using this instrument, and I see that we have a wide range of people attending today, is, striking this balance, as I mentioned, between having a really long tool and then something that's easy for providers to apply. So if there's anyone that's attending today that is working in service provision or as a provider themselves, or works with training providers and has also kind of try to address a similar thing where you want to have a complex kind of assessment, but you also need to be, careful with providers' time as you're creating instruments that you want them to be using. So I see a question from Tori. Thank you, Tori, for the question. Did you consider, which I'll read out, did you consider using a definition of gender that's non-binary as the basis for instrument development? And Tori, thank you for this question. And the answer is yes. And you know, Tori, full disclosure, Tori and I also know each other from Tulane, and then also that some of the previous work that I've done has kind of tried to think about sexual orientation and gender identity and how to define these concepts in global settings and how to appropriately be able to measure and create domains, or we need to put people in boxes sometimes for our different instruments. And so how to do that appropriately around these concepts that can differ and be non-binary in different ways across contexts. And I think in trying to develop the tool to align both with what was presented in terms of gender with the gender competency framework, but in a way that would be easily applicable with where the current state of the world is, and having discussions about non-binary gender identities and how that aligns with some of these gender-related constructs and norms to be outside of thinking of cisgender men and cisgender women, that we didn't find a way to do that in a way that would not overly be complex and something that could be applicable across global settings within the complexity of each of these dimensions that we were already trying to tackle. So that is definitely a limitation of the tool, but we didn't feel like there was enough to be able to design something more specific that are broad there.
So then we have Samantha Wild asking, did the team start to notice any themes in the KSAs that providers in Ghana felt comfortable or practiced at versus competencies that were new or unfamiliar?
That's a great question. Thank you. I will say the communication, the counseling and communication. So there are two areas related to counseling and communication, and like gender sensitive communication and couples communication. And so actually in those areas, they felt very comfortable with the skills. It was linking the reason why you might use a certain skill or counseling skill, like visual aids for people who have different levels of literacy, for example, is because there might be gender factors that influence who has access to education and information in a formal setting. And so those were easier. I would say that the ones that they were kind of in the middle with were more like the male engagement. And then the more complex ones might be around agency and the gender-based violence one a little bit. Has there been translating questions into local languages, and how would you do that? So there has not been translation yet, and we are purposely piloting in places where the instrument can be used in English. And the reason for that is that it would be kind of like jumping over a step. So first we have to make sure that even in English, the questions are clear and measuring what we intend them to measure. And then it would be an additional step of like, okay, well, the initial structure is appropriate. Now is a translation also meaningful and capturing the same intent. And so until we had that foundation, we can't then like test whether the translation is actually appropriate for these concepts. So we need to get it right, at least in one language, which we've been working in English, and then look at adapting it once we have what we feel confident is a good measure. So Carrie McGuire asks Macquarie, I'm curious if you've given thought to how this could be used to provide an assessment at a facility level versus an individual provider level, either in terms of applying the tool or measurement of the results. Well, so at the facility level, actually, I think it would be really ideal for providers, a group of providers to be taking this assessment. And then, as I mentioned, the discussion guide has some open-ended questions to facilitate a dialogue among people who have just taken the assessment, to talk about their responses and where they think as a group they have strengths and weaknesses, and then to reflect on why. So also to reflect on some of the kind of organizational, institutional, or system kind of factors that might be influencing their work. They may have knowledge in an area, but there could be something preventing like their application of skills in that area. And so in that sense, in aggregate, it could be useful. It's not, this particular instrument is not looking at facility level factors, although we very recently came upon an instrument from Japigo that does look at, it's a little bit more like a facility assessment type thing to look at, like, are these different structures in place that would support the provision of gender sensitive and gender competent services. But I think used as a team, this does not, though, get at system level factors.
In the chat, there's a comment from Sarah and Samantha.
Okay, so from Samantha, well said on the binary question, would also add the root of this is dignity and respect and tailoring services to individuals. I think everyone can see the chat, just not the
Yes.
Q&A.
Mm-hmm.
Oh, great. So from Sarah, looking for ways to work this into a spa. I hope that this will be useful for you in doing that. And I think what makes me, I mean, I'm very excited about this work. What makes me extra excited is the work that Samantha and USAID have done, so that you have this assessment, but you also have direct access to this online tool that's very interactive, has great visuals, and goes into depth in each of these dimensions. It's not overly long to take, and it is broken out. You can take specific modules and access that you learn in course. So it's, not just, well, you can measure this and then this is where you are, but there's a direct link to something that you can do to learn more about that particular skill area.
I don't see any other questions. Katherine, have you given any thought to how this could potentially apply to other health service areas?
I think it's interesting because my first response to one of the questions about which of the tools were, which aspect of it was more modules was easy to apply. I think ones around counseling and communication could easily, I don't know to say easily, but I do see some ability for that to be transposed into other areas. I do some work in HIV, and so I can see how maybe transposing that to or translating that into how you do counseling for health services would work directly. There's also the GBV module, and I think that could easily be transferred. The agency, I think the individual agency, I think, is one of the really strongest parts of the dimension, a very critical element. And I think that's a unique aspect of family planning. Of course, we want all of our clients to be making the decisions they want for their health, but that's specifically important in family planning is there are all these other factors. So yeah, I think the communication and counseling are the ones most ripe for easy transfer.
Okay. Well, if there's no other questions or comments, we can give people 10 minutes back to their day. And thank you for joining. Let's see, this is being recorded, and we will send a link to the recording and the materials after this to everyone who's registered for the webinar, so that will be coming your way. And also please be on the lookout for the announcement for the next webinar in the series that'll be going out in the next week. And these materials, Katherine, the actual scale, what is your predicted timeline in terms of when there'd be a publicly available draft?
I think since we are in the field right now with Uganda and we need to also do the TA work to refine the discussion guide, I would be looking more around May, June for a published document. Great.
So you can be on the lookout for that, and we announce new materials on social media and on our website, of course, and also through listserv. So just please keep a lookout, and thanks so much for everyone taking the time out of your day. And we look forward to seeing you in the future.
Right. And I have to say from New Orleans, happy Mardi Gras, everyone.
Oh, yes, yes, yes. We've had king cakes out on display in North Carolina, but it doesn't have the same feeling. So.
Oh, that's fantastic. And don't schedule any meetings with your New Orleans friends on Tuesday. Next week. You can, but it will be a different meeting.
Okay, we'll make a note of that. Okay, thanks, everyone.
Thanks.
Bye.